Hi, I'm Jack Cush with RheumNow. I have a panel of good friends, and we're going to talk about advances in rheumatoid arthritis from EULAR 2021. Let's begin. First, I should say that John Kaye has been our lead faculty member on RheumNow for rheumatoid arthritis for the last several meetings and did another stellar job for this meeting. I want the faculty to introduce themselves. Let's start with John.
Hi, I'm Jonathan Kaye from University of Massachusetts Medical School in Worcester, Massachusetts. I'm glad to be here.
I'm Kathryn Dao. I'm in Dallas. I'm Jack's better half. You probably read some of my blogs and follow me on Twitter. Glad to be here, Jack.
I'm David Liew from Melbourne, Australia. I'm really glad to join you too.
And I'm Meral Ramahi from Cleveland, Ohio. Nice to join you guys today.
Yeah, so all these are great friends. I want to say I visited Cleveland Clinic last year and met Meral, and boy, we had a great time there, and I got her to join the faculty. She's been great ever since. So I wanted our faculty to tell us the study in rheumatoid arthritis that they thought was most interesting, and then we'll get some commentary from our other faculty about those studies. Let's begin with John.
I'm going to talk about two abstracts. I did a number of videos, so I'm going to talk about two abstracts that I didn't include. The first is poster number 210, and this comes from the Mayo Clinic from Samori and colleagues who looked at the incidence and risk factors for rheumatoid arthritis-associated interstitial lung disease. They have a cohort of incident rheumatoid arthritis among residents of Olmsted County, and between 1999 and 2014, they had 645 residents diagnosed with rheumatoid arthritis, and they found that the incidence of interstitial lung disease in that population was 4% at 5 years, 8% at 10 years, 9% at 15 years, and 12% at 20 years following the rheumatoid arthritis diagnosis. So this is a prevalent and increasingly prevalent complication of rheumatoid arthritis. So how do we treat it? And there was an oral presentation, OP124, that came from Newcastle in the UK, presented by Dr. Kelly on behalf of the INBUILD trial investigators. And the INBUILD trial was published in the New England Journal of Medicine in 2019, and it looked at nintedanib, which is a tyrosine kinase inhibitor, and its effect on interstitial lung disease, secondary interstitial lung disease, not idiopathic. And in that study, there were a number of patients with rheumatoid arthritis. 663 subjects in the entire trial, 89 had rheumatoid arthritis interstitial lung disease, and they were randomized 42 to the drug nintedanib and 47 to placebo. And they found that there was a greater rate of decline in the forced vital capacity over 1 year in the nintedanib treated group compared to the placebo group. And this difference of 117 milliliters per year was statistically significant. So this study concluded that the drug nintedanib slowed the rate of decline in forced vital capacity in patients with progressive fibrosing rheumatoid arthritis interstitial lung disease. The major side effect of this drug, like other tyrosine kinase inhibitors used to treat fibrosis, was diarrhea, but patients were able to tolerate that reasonably. So this is an interesting trial of a drug that can be used to treat interstitial lung disease in our patients with rheumatoid arthritis, and the Mayo Clinic pointed out that that is an increasingly prevalent condition. So those are the two abstracts that I picked.
So the ILD in RA especially was a big topic throughout the meeting. A lot of presentations, more on MUC5B from Jeff Sparks and his group, and a lot of other presentations. The INBUILD study was interesting, and I don't know what to think about it. They showed the same data as nintedanib in systemic sclerosis, which became an indication. But this was a study that was meant to be like a Swiss Army knife, meaning they wanted all connective tissue disease under the study. Over 600 patients, but only 80 had RA. Is that appropriately powered enough to know what to do with RA? And, despite the claims here that it slows progression, I really don't see rheums running out and writing for a whole lot of nintedanib.
Well, it's a drug that's not that well tolerated. I used to use imatinib to treat patients with nephrogenic systemic fibrosis, and patients developed gastrointestinal complications and couldn't continue taking that medication for many of them. So the diarrhea is probably a limiting factor. It just decreases the progression of forced vital capacity decrease. It doesn't do anything for mortality in the larger study.
Right.
It's an expensive medication that would be added on to other expensive medications to treat rheumatoid arthritis. I think that we need a larger study if we're going to use it in rheumatoid arthritis, and it's probably not going to catch on.
Yeah, I think that last point was important, that it doesn't change mortality. Scleroderma didn't change mortality, didn't change skin sores. So the question is going to be, will this tyrosine kinase inhibitor actually help RA? We don't know that. I wouldn't expect it. David?
Well, I think our pulmonology colleagues are getting quite familiar with this already from the IPF indication. I think it comes in for a lot of group about the actual magnitude of the effect, and people, I guess, dismiss 110 mils. But I think if you've got a properly progressively fibrosing phenotype where you are losing lung volume rapidly, being able to see that first of all, 110 mils matters. And secondly, I guess it's a parting of the ways in terms of the trajectory of where you go with this. This is lung function you don't get back. So, I mean, I guess the counter is that there's got to be a role for something to do in something in this space. And whether nintedanib is the answer or not, or nintedanib in isolation is the answer or not. But I don't think that the RA-ILD therapeutic story is finished quite yet.
You know, a lot of our colleagues really want to know, what are you guys doing to treat your ILD, your chronic lungers and whatnot? Is there anything that you're doing that you think is particularly great other than sending them to your pulmonary colleagues and asking help? Kathryn, what do you do?
Control their disease. That's one of the best things that you can do for the patient. There's actually an abstract in there about how Orencia can also help with patients with RA-ILD that I saw presented at EULAR here. And, you know, basically, if the patient's disease is active, I mean, that's basically systemic inflammation. So to me, I don't know that it'd be worthwhile with the cost of nintedanib versus, you know, the cost of controlling the disease. So I don't know. What about you, Meral?
Meral, do you have any suggestions?
I echo all the sentiments that have been expressed thus far. I think the RA-ILD therapeutic story, there's more to come from that. And I think, as Kathryn mentioned, for me, I found success in controlling the disease activity of rheumatoid arthritis and tackling the ILD.
Okay, let's move on. John, go ahead.
Yeah, I would just say, to underscore that point, I think the overarching theme for all of the comorbidities is control of disease activity. So what we're seeing, not only for interstitial lung disease, but also cardiovascular complications and others, that better disease control is the way to go.
Yeah, I'm going to endorse that because it sounds like the right thing to do, but I'll also say, not a lot of evidence that control of disease activity really affects the lung outcome in RA. I mean, it's a little scary there, and that's one of the things like scleroderma, not much you can do, but I would endorse better disease control. Kathryn, you have another presentation?
I do. One of the posters here that I thought was really fascinating was poster 0385. And it begs the question, is there really a sentinel joint in rheumatoid arthritis? So what this study is it's a study from the Netherlands. They looked at 524 preclinical RA. So these patients, they have arthralgias, morning stiffness of an hour, and they may or may not have a positive ACPA. So CCP positive, maybe, maybe not. And what they did was they scanned these patients using an MRI of their MCPs, their wrists, and their MTPs. And they followed them over a period of 2 years. So they wanted to see how many of them progressed to rheumatoid arthritis. And what was interesting was about a quarter of them had abnormal intermetatarsal bursitis. And they found that if you're ACPA positive with an abnormal intermetatarsal bursitis, you have a greater than 70% chance of developing rheumatoid arthritis over a year. So, I mean, that's huge if we can predict who can develop rheumatoid arthritis. And these are the patients that we have to pay attention to, where early and aggressive treatment and the window of opportunity is there for them. The other thing that the study authors mentioned was that maybe we haven't realized this, but there's actually synovial lining in the metatarsal bursal region. You know, how we call the fingernail anthesis, that's an anthesis. Well, the intermetatarsal bursa is a synovial site. So I just thought this was fascinating because, you know, it's like, forget about scanning their MRI MCPs. Can we just scan their feet? And perhaps, and I've looked on PubMed and everything. I haven't seen a study using ultrasound because that would be so much cheaper and you can predict who will progress on to rheumatoid arthritis. Does anybody know? I mean, have you tried ultrasound and looking at that particular joint?
Well, actually, Paul Emery looked at the predictive value of ultrasound in development of RA and showed that finding tenosynovitis and even synovitis, but mainly tenosynovitis, along with CCP, did the same thing as you're suggesting, you know, much higher rates. So preclinical RA, you're seropositive, let's say CCP, your odds of developing RA is 20 to 60%. What you're talking about supersedes that, and that would be an important advance. And we do know from our training, I don't know if I remember the actual original reports, but the foot is probably the best place to look for early RA, not the hand, like we always think. So I think this was really compelling, and the pictures were really cool if you looked at them.
Absolutely. Can I coin a term, Jack?
Yeah.
Non-radiographic RA.
Oh my God. Oh my God. All right. You now got permanent membership in OMERACT and ASAS. Good luck with that. Oh my goodness. Does anybody do ultrasound in preclinical RA?
I love ultrasound. For me, I was fascinated by this study. I'm glad you brought it up. I thought it was a great study, and thinking about looking at a different joint that we don't, or a different space that we don't normally look at, I thought it was great. I do use ultrasound a lot, and I often am asked, you know, you use ultrasound a lot, why? And I love it. It's cheap. It's pretty efficient, especially if you have MSK radiologists that are well-versed in reading them. And I found that it has helped me make decisions in preclinical RA, and even in RA that's not well controlled, and trying to convince the patient to advance therapy or to change therapy, showing them objective findings with an ultrasound showing tenosynovitis or synovitis.
David, does this worry you? The idea that you're doing an ultra-sensitive test to find something that's not clinically apparent, and now are you going to hang your hat on this and put them on a DMARD or a biologic?
Jack, you read my mind. And I think this is the issue, that when I've brought up these studies before with my colleagues, and, you know, previously, you know, the Paul Emery studies with power Doppler and tenosynovitis, like you say, the questions always is, well, what do we do about it? Are you going to go start treating these pre-RA patients with the knowledge that you're really walking into a zone where there's no data to suggest that treating, as you've talked about many times, Jack, there's no data for treating these patients in terms of preventing RA. So, I don't know if I always get to these patients. I don't know if they make their way into my clinic before would they actually, you know, often when they're at this point. But B, what do I do when they're there? So, nevertheless, I find this fascinating, but I'm not sure what I can do about it in practice.
Well, it makes a lot of sense to use ultrasound in the foot because, in contrast to the hand, where physical examination is pretty good, it's very hard to detect swelling in a foot unless it's relatively overt. Patients oftentimes will have erosions in the foot when they don't have them in the hand, suggesting that that's really where the money is. So this study prompts me to order ultrasound or get my colleagues to look at ultrasound on my patient's feet.
Yeah, I think if anything, now there's where MR studies. I'm not willing to do MR, but I'm certainly willing to do ultrasound, especially if I have someone experienced like Meral in my clinic who can help me out with that. So I must say our ultrasound machine is collecting dust, and shame on me for that. David, what do you have that's interesting?
I just really wanted to briefly swing by the some pregnancy data, because I think there was a lot of great pregnancy data at this meeting, but particularly my attention was caught by oral presentation 0210, which was Swedish-Danish linked data. So there were investigators from Karolinska and the Rigshospitalet who looked at 1,739 rheumatoid arthritis patients, matched them 10 times to controls, and tried to tease apart the issues that we have with disease activity and treatment. Because I think we're often in a situation where we've got someone with grumbling disease, or even more than that, who becomes pregnant, and how hard do we go on the disease control versus versus what kind of risks do we see from the therapies that we use. And in particular, thinking about things like steroids as we get further on in term. So what these investigators tried to do was tease that apart. They saw that the risk of preterm birth and small for gestational age were higher in this population. They saw that was associated with disease activity. They also saw that it was associated with use of prednisolone and biologics. But then when you try and tease it out, especially in terms of the prednisolone, and you try and correct for that, it's very hard to completely exonerate steroids. But the ultimate question is, I think at the end of it, I don't think anyone really knows how much is disease activity and how much are therapeutics. And it's probably a space to walk in with caution.
Yeah, Kathryn,
So pregnancy is my area of interest. And I really have paid attention to a lot of the pregnancy data and things like that. And I applaud the team looking at that study. One thing that I thought was very interesting was the UCB database of prospective pregnancies. So this isn't a retrospective study. This is prospective studies of almost 1,400 pregnancies, 1,425 pregnancy outcomes. And it's really clear. I mean, this is very, very clear. So there were 88% live births, 10% pregnancy loss. So if you look at all around pregnancy loss, that's usually about 20%. So half, it's cut by half, only 10% pregnancy loss in patients on certolizumab, 0.8% stillbirths, 2.4% congenital malformation. All right, so normally if you were to look at the general population who don't have RA, who don't have, these medications, congenital malformations is 3 to 5%. So with the certolizumab registry, it's only 2.4%. But what they found was so highly associated with pregnancy loss is Crohn's disease, active Crohn's, NSAIDs, which is, there's always that kind of controversy that we've known about NSAIDs and pregnancy loss, and methotrexate. Well, methotrexate is not surprising because it's an abortifactant. That's for pregnancy loss early on. With regards to preterm labor, highly associated with glucocorticoids and maternal infection. So, and then low birth weight associated with RA disease activity and glucocorticoids. So that was, to me, a clear-cut thing that TNF inhibitors are safe in pregnancy for sure, and that really glucocorticoids are not. And we should try to control disease activity.
These kinds of studies have really informed us greatly. So you have these sort of linked databases like you have in Switzerland, this committed cohort analysis like you have with UCB. And I don't know if the audience is familiar with the Piano study done by Mahadevan and colleagues at UCSF, and nationwide study in Crohn's disease and and ulcerative colitis, where they either got thiopurines, TNF inhibitors, combo, or nothing. Again, showing that none of these drugs cause malformations, but they do cause, preterm births, increase in spontaneous abortions, and there are other things, little caveats like we were seeing here. But these should really inform us on how to better manage patients. And if you manage RA, you're going to be managing pregnancy in RA. And that's why the ACR guidelines are helpful. That's why these particular studies are also helpful.
And don't forget about the role of the father in pregnancy. There were two interesting presentations by Perez Garcia and colleagues who looked at a Dutch cohort of about 600 men, and they found that there was a higher rate of miscarriage in pregnancies where the father had been diagnosed with inflammatory arthritis at the time of conception compared to those where the father had not yet been diagnosed with inflammatory arthritis. So the message there is that if the father has inflammatory arthritis, the mother, even if she doesn't have arthritis, should be followed more closely because of the increased risk of miscarriage.
And again, they should look at the ACR guidelines paper on reproductive health. It basically says paternal exposures to our drugs don't factor. I mean, other than Cytoxan, don't factor. Father, mycophenolate major X, don't go there in women with pregnancy, but fathers on mycophenolate are okay. The only one I think that they had a negative statement about, which everyone should have a negative statement about, is Cytoxan, but this is a different scenario John's talking about. I think it's the health of the the maternal egg and the paternal sperm that can be influenced by activity. Maybe more so than the drugs. It's again, the analyses thus far don't really show anything. So, Meral, what's your favorite abstract from this meeting?
So there was a lot of great content at EULAR this year. What I especially enjoy is posters or presentations that tackle questions that are of interest to patients. So have you ever had a patient ask you whether or not he or she will be at an increased risk for developing other autoimmune diseases because of a positive serological marker for rheumatoid arthritis relative to an individual that has seronegative RA? So poster 0313 examined that question further by determining the prevalence and incidence of autoimmunity in seropositive compared with seronegative patients with RA in the Danish registry. The study population was about 12,500 patients who were recently diagnosed with RA, 8,000 of which, or about 64%, were seropositive. They defined polyautoimmunity as the presence of more than one autoimmune disease, which included multiple sclerosis, lichen sclerosis, inflammatory bowel disease, type 1 diabetes, and autoimmune thyroid disease. It assessed the point prevalence of autoimmune diseases at the time of diagnosis of RA and the incidence of polyautoimmunity during a 5-year follow-up. The point prevalence was adjusted for age, sex, and tobacco smoking status, whereas the incidence was adjusted for sex, age, HAC-DI, DAS28-CRP, whether or not they were treated with DMARDs, and cigarette smoking. So did patients with seropositive RA develop more general autoimmune diseases compared to seronegative RA? What do you guys think before I give the answer?
Does Sjogren's count as an autoimmune disease?
That wasn't included in there, but that's a very fair and important question. Wasn't included in the diagram they had.
I would think yes.
Yeah?
I say no.
No? David, what do you think?
I'm not sure what seronegative disease is, and in general, I think that's probably the issue. I mean, I would have thought yes immediately. If you asked me as a reflex, caught me in the lift and cornered me, I'd say yes.
David, you can phone a friend like Dr. Kaye.
Yeah.
I'd love to phone Dr. Kaye. Dr. Kaye, what can I do in this situation? Help me.
I heard that abstract. I think the answer is yes, but I don't recall exactly. So I'm not going to be much help to you as a friend.
Yeah, this is what was so unique about this abstract is everyone would think yes, but actually was no. Seropositive patients had a lower prevalence of polyautoimmunity compared to seronegative RA. And there was no significant difference in incidence during a 5-year follow-up when comparing the two groups. I thought that was really interesting. But David, you brought up a really good point. Seronegative RA is very heterogeneous. What does that really mean? And what do we make of this? But it was a very interesting study.
So I want to end by doing like a lightning round, and just give me an abstract or two that you also thought was interesting and noteworthy. I'll say two quickly. One from the rabbit registry, OP0116, showed that elderly patients with RA can safely get biologics and JAK inhibitors without an added increase in infection. We do worry about serious infection. In being elderly is a risk factor for infection, and truly, the elderly across the board had higher SIE rates. But when you compare it to those that are on just DMARDs versus those on biologics or JAKs, there was no higher rate. And we do know there's a significant problem of the elderly being undertreated, often because of comorbidity, finance, whatever reason, worry about infection. And their data suggested that maybe that's not right. My other one is passive smoke exposure, causing being a risk factor for developing RA. That was nicely shown in another abstract, OP0012. John, anything else?
So don't forget the Mayo Clinic studies of dementia. Mayo Clinic did some very nice population studies looking at the incidence of dementia in their cohorts. They found that there was an increased incidence of dementia among patients with seropositive compared to seronegative rheumatoid arthritis. But interestingly, looking at cohorts between 1980 and 2010 beginning, followed up as far as 2019, there was a decrease in the incidence of dementia in the cohort in the 2000s. So the increase in effective anti-inflammatory drug therapy may decrease the incidence of dementia among patients with rheumatoid arthritis. So this is an interesting topic, one that I think deserves much more study.
I want our faculty to note that Dr. Kaye began with don't forget this abstract about dementia. I don't know why he's pointing that at me or not, but Kathryn, did you have one to talk about?
Sure. I mean, one of the things that I just thought was fascinating and very impactful. We all have been affected by COVID-19 through the pandemic, and we all want everybody to get vaccinated. Well, there was this study that showed that what they did was a video detailing, the benefits of the vaccine, dispelling the myths. And what they did was they went ahead and sent it out to all their patients. This is the first large study of basically video-based sent by SMS text. And they found that from before they sent the text to after they sent the text, after a couple of months, the rate of vaccination shot up, the rate of hesitancy went down. I mean, think how powerful this is. And we can educate patients so much better by SMS text or by other means of accessibility, and especially the immigrant population where they're afraid to come forward with regards to their status, or people who don't have access to good information. There's a lot of misinformation out there. So to me, this was highly impactful and something to look out for in the future.
Using technology to better communicate with your patients. This should be done. David.
Well, getting on the COVID vaccine bandwagon, I was really interested by the Israeli data for the mRNA vaccination over there in our rheumatology patients, and just getting the reassurance that we see it's safe, it's effective, and that we don't see flares in disease. The Israelis have got a head start on the rest of the world in terms of this vaccination. I think it gives us really great reassurance to just go ahead and get this done with our patients.
Okay. Meral, anything else that you thought was worth mentioning?
Yeah, I thought poster 0100, which talked about whether or not vitamin D level can predict response to RA treatment. I thought that was very interesting. It looked at 236 RA patients, 57% of which were started on a TNF inhibitor. And at 1 year, it was suggesting that patients were 4 times less likely to respond if they had a low vitamin D. So I thought that was very interesting and something for us to all watch out for.
So who here is taking their vitamin D every morning? Uh-oh.
I go out for a walk and get some sunshine.
Oh, there you go. And but there is no sunshine right now down under in Australia and New Zealand.
It's cold and miserable outside. This is the one time of year where this question doesn't fare well. The one time of year.
All right, I want to thank the panel for a great discussion and a lot of great coverage of the meeting. You all did a stellar job informing the masses about the good stuff that came out of EULAR, and there was a lot to look at, and you really filtered it and really delivered it really well. So we'll see you at ACR.
Look forward to it. Thanks, Jack.
Thank you, guys.
Thank you.